Can you?
Yes, madam.
I will put that into the presentation mode as it is now 9:05. We will start. People, others, hopefully they will join. And can you please label yourselves with your name and the index number that is for register marking purposes. Can you now see the presentation mode? Can you see the presentation in presentation mode?
Yes, madam.
Okay.
Recording in progress.
Okay, hope all of you have got the question. Can you see the slides? Question is, can you see the slides? Because I did some changes. Still, I just want to verify whether you can see the slide.
Yes, madam. We can.
Okay. The question is 17-year-old boy with type 1 diabetes mellitus is found to have following investigations in a routine follow-up visit. Explain now when you go through the question, you can see we have given you a young boy with type 1 diabetes mellitus. So that means the patient is having type 1 diabetes mellitus having absolute insulin deficiency. And the rest of the question is found to have following investigation findings in a routine follow-up visit. He has come for a routine follow-up visit to the clinic, not in an emergency situation, but for a routine clinic follow-up. So then when you investigate the patient, you see these changes in his biochemical tests. Explain the biochemical basis for the following investigation findings. So what are the investigations that we have given? Fasting plasma glucose concentration with the patient findings and the reference ranges. Don't worry too much to remember the reference ranges, because in the exam, in the essay paper, you are given with reference ranges. And we have given you total serum cholesterol concentration that and the patient findings and the reference ranges. And then we have given you the blood glycated hemoglobin percentage, that is 10%. So when you look at these findings at a glance, you will be able to understand, okay, this patient is not under good control. His glycemic control is not good using these values. You can, at a glance, you can identify. Then what have been asked is, explain the biochemical basis for the following investigations. Can somebody read the question? For fasting plus answer, can somebody read the answer for fasting plasma glucose concentration, that part? Anybody? Can you please? Can I ask? Madapul is there. Okay. Can I ask Punsara? Hello, Punsara.
Yes, madam.
Punsara, sorry. I just remember. Yes. Okay. Sorry.
Diabetes mellitus is syndrome of chronic hyperglycemia due to absolute or relative insulin deficiency or both. In type 1 diabetes mellitus, there is a absolute insulin deficiency because insulin production is reduced due to destruction of pancreatic beta cells. Mm, His fasting blood glucose level is higher than the normal range. That means he has hyperglycemia. His insulin glucagon ratio is lower than the normal. Therefore, gluconeogenesis and glycogenolysis increased, and glycolysis and glycogen synthesis are reduced. Glucose entry into the cell uh, into the insulin dependent cells, heart, adipose tissue, skeletal muscles is reduced due to the inhibition of GLUT4 transporters and glycolysis.
Hello.
Hello.
Okay. And now I can hear you. It got little disconnected. Can you,
Mm.
is it finish or?
No, madam.
Oh.
And glycolysis is suppressed by low insulin glucagon ratio by inhibition of
Hello?
um,
Hello? Sarah, are you there?
hello, madam. Yes.
Yeah. Can you proceed? We couldn't hear the last part, letter part of your answer.
Um, Glycolysis is suppressed by
Shall I ask somebody else to read? Anybody who is having good connection, can you please read the answer quickly? Is Kirti there?
Yes, madam.
Can you read, please?
Okay, madam.
But your voice is little faint.
Now, madam.
Now, okay.
Okay, madam. Diabetes mellitus is a group of metabolic disease characterized by hyperglycemia resulting from defects of insulin secretion, insulin action, or both. So, in this case of diabetes, type 1 diabetes mellitus, there is a loss of insulin producing beta cells. So that results in the loss of insulin secretion. Therefore, there is an absolute insulin deficiency. So, insulin is a peptide hormone which facilitates the uptake of glucose in the plasma into cells directly or indirectly. There are insulin dependent tissues like the adipose tissue, cardiac muscles, and the skeletal muscle, which take in glucose in the presence of insulin via the GLUT4 transporters, which is an direct action of insulin. Whereas liver, which is an insulin independent tissue, needs insulin for the activity of glucokinase, which phosphorylates the glucose taken inside the cell and traps it within. This is an indirect action of insulin. So after a meal, when the glucose level in the blood is elevated, the glucokinase in pancreas, which has a higher Km value, will cause the release of insulin from the beta cells. So this insulin will act on the insulin dependent tissues and facilitate the uptake of glucose by increasing the number of GLUT4 transporters. Liver will also take in glucose independent of insulin, but trapping of glucose within the hepatocyte requires insulin. As a result, the glucose level in plasma will reduce to the normal range. But due to absolute insulin deficiency in type 1 diabetes mellitus, glucose will not be taken into insulin dependent tissues and glucose cannot be trapped inside the liver cells. Therefore, they have the chance to get back into the plasma. And also, since the insulin is to glucagon ratio is reduced in this case, there is an increased activation of the counter regulatory mechanisms like increased activity of hormones of cortisol and glucagon. Thus, gluconeogenesis and glycogenolysis increases and further glucose concentration in the blood increases. As a result, even in between a meal, that is at the fasting stage, the plasma glucose level will be greater than 99 milligrams per deciliter. This is why the patient has elevated blood glucose level leading to hyperglycemia. That's all, madam.
Okay, we could clearly hear your answer. That's a good answer, but we can little cut short the answer, the initial part. You can see in this question how marks are being allocated. And if you take, there is no 100 in it. 15, 20, 15. And there are some more in that question for you to answer. So how long, what is the time duration for a one question? So depending on the time allocation and the marks allocation, you have to plan the answer, right? Certain part we can reduce in the answer. So we are going to answer for what has happened to fasting plasma glucose concentration in this patient. So when you start answering, you have to first tell what you observe. What you observe. So there you have to tell this fasting plasma glucose. Can you see the slides?
Yes, madam.
This patient is having elevated fasting plasma glucose concentration, indicating that the patient is having poor glycemic control. So then you start with what is blood glucose and how it is maintained in simple. Blood glucose concentration, as we all know, it depends on many things and it's kind of a balance. Blood glucose concentration maintains in a very narrow range by these factors. It depends on dietary glucose output, glycogen synthesis and breakdown, the balance of it, gluconeogenesis, and the ability of tissues to utilize glucose. So in fasting, what does that mean? We have taken the blood sample for the estimation of glucose after 8 hours of fasting. So during fasting, what are the factors that come into play? There was more or less no dietary glucose output. There is minimal glycogen synthesis or no glycogen synthesis. The main things that will play in the maintenance of fasting plasma glucose is the balance between the gluconeogenesis, glycogenolysis, and how the tissues take up glucose. Right? So in this patient, what happens? This patient is having absolute insulin deficiency. So when the patient is having absolute insulin deficiency, what happens to the uptake of glucose by the peripheral tissues? When there is absolute insulin deficiency, the expression of GLUT4 transporters on the insulin-dependent tissues. You have to give some examples: skeletal muscles, adipose tissues, and the heart muscles. The expression of GLUT4 transporters get reduced when there is absolute insulin deficiency. So then what happens? There is reduced uptake of glucose from the peripheral tissues. So that contributes in these patients to elevate the blood glucose level during fasting because their peripheral uptake of glucose is reduced. So we have described one factor for this elevation of fasting blood glucose level in this patient. What are the others? And we know these patients, they have reduced insulin to glucagon ratio as insulin level is low. When there is reduced insulin to glucagon ratio, what happens to counter-regulatory mechanisms? These counter-regulatory mechanisms such as gluconeogenesis, glycogenolysis get activated, and ultimately that will lead to increased hepatic output of glucose. That again will increase the blood glucose level. So how this gluconeogenesis get increased? It is basically due to the increased availability of substrate such as oxaloacetate. As we know, in diabetes mellitus, there is suppression of TCA cycle. Oxaloacetate is a substrate for TCA cycle. So when that is suppressed, this oxaloacetate involve more in the gluconeogenesis. Because of increased substrate availability and the increased enzyme activity due to in activation of glucagon, there is enhancement of the gluconeogenesis in these patients. So once you tell this increased gluconeogenesis, you have to say why increased gluconeogenesis. Say what happens to this hormone balance, and then with the substrate change in the substrate availability and the enzyme activity, there is increased gluconeogenesis in these patients, releasing glucose into blood. That we explain the second thing. We explain reduced substrate, then we explain increased gluconeogenesis, and then coming into glycogenolysis. Due to the change in this insulin to glucagon ratio or the reduction of that ratio, there is increased activation of glycogen phosphorylase enzyme in the liver, which is necessary for the breakdown of stored glycogen in the liver. So in these patients, during fasting, there is increased gluconeogenesis, increased glycogenolysis, and also due to the disease itself, they have reduced uptake of glucose by the tissues. These three main things you have to explain under this elevated fasting plasma glucose concentration in this type 1 diabetes mellitus patient. Right? Okay, hope you are clear. There are some questions in the chat. I will come to that. If I forget, just remind me, right? After finishing the tute, I will come back to the chat. Okay. Shall we move to the next? Can somebody read the next answer for the cholesterol elevation? Shall I ask somebody or will somebody read?
May I try, madam?
Please, yes.
As insulin and to glucagon ratio decreases in diabetes mellitus, there is an induced activity of hormone-sensitive lipase. This increases the lipolysis in adipose tissues. The increase in lipolysis in adipose tissues releases free fatty acids into blood, which is then taken up by the liver. In the liver, it can either be converted into triglycerides or it can undergo beta oxidation. During as beta oxidation occurs, there is an excess production of acetyl-CoA, which instead of undergoing TCA cycle undergoes cholesterol production due to suppression of TCA cycle. This consequently leads to increased cholesterol production and hypercholesterolemia. That's it, madam. I wrote.
Okay, you are okay. We will discuss. No, that's a fairly good answer. We can elaborate on that. So now here we have asked, if we go back to the question, see, total serum cholesterol. That is 240. You can see the reference range less than 200. There is little elevation. So how we are going to explain? You can first say what is the problem with the, can you see the slides?
Yes, madam.
Okay. This patient, the problem is having absolute insulin deficiency. So the insulin to glucagon ratio is low. When that happens, what happens at the adipose tissue? There is lipolysis. There is lipolysis. There is lipolysis, and I'm just trying to see. Just give me 1 second. I tried to record this, but it seems it's not recording. I don't. We'll see. So when there is reduced insulin to glucagon ratio, there is lipolysis, increased lipolysis at the adipose tissues due to the activation of hormone sensitive lipase. So you have to remember these terms: lipolysis, hormone sensitive lipase. So with this lipolysis, what happens? There is mobilization of stored triglycerides at the adipose tissues, and there is release of free fatty acid and glycerol into blood, and then those are transported to liver bound to albumin, and liver then takes up these fatty acids and glycerol. And then what happens to these fatty acids in the liver? These fatty acids can involve in the production of triglycerides, and also these fatty acids, when they enter into the hepatocytes, they can undergo beta oxidation. At the end of beta oxidation, there is production of acetyl-CoA, and this acetyl-CoA is the precursor for fatty acid, endogenous fatty acid synthesis, and also endogenous synthesis of cholesterol. So, when there is excess acetyl-CoA, which cannot be managed by the TCA cycle for the energy production, these are diverted to produce cholesterol and fatty acids. That is, so when there is increased fatty acid synthesis, what happens ultimately? There is increased triglyceride production. When the diabetes is not under control, because of mobilization of this stored fat in the adipose tissues, there is increased production of fat in the liver. So when there is increased production, what happens? There is increased output of very low density lipoprotein from the liver. Why? This VLDL is the lipoprotein which is transporting lipid from the liver to the peripheral tissues for the storage and also for the oxidation. So, VLDL contains cholesterol, triglyceride, phospholipid, and cholesterol esters, apoproteins. So, when there is increased cholesterol production and triglyceride production in the liver, there is more VLDL produced in these uncontrolled patients, and there is release of those into blood. So, then what happens in the peripheral tissues? This VLDL is producing intermediate density lipoprotein. I think you can remember, at the peripheral tissues, at the adipose tissues, by the lipoprotein lipase enzyme present in the capillary endothelium. triglyceride present in the VLDL is hydrolyzed into fatty acids and glycerol, and some triglyceride present that was present in VLDL is removed. So then producing intermediate density lipoprotein, and after that this is going back to liver, maybe as IDL or in the form of VLDL remnant. Some of those are further metabolized by hepatic lipase. This HL means hepatic lipase. Hepatic lipase enzyme again present in the vascular endothelium of hepatic vasculature. So the triglyceride present in IDL is being further removed by the action of hepatic lipase enzyme, and LDL is produced. So as you can see, when more and more VLDL is produced from the liver, more LDL will be there in the blood. When more VLDL, more LDL is there in the blood, that ultimately increases the blood cholesterol level. And if the question has been asked in another way, like elevated triglycerides, so in the same way you can explain, because VLDL is the main lipoprotein transporting triglycerides in the blood. In fasting sample, VLDL is the major lipoprotein having a lot of triglyceride. In diabetes patients, as we now explained, VLDL output from the liver is high, and at the same time, in these patients, lipoprotein lipase activity is reduced. So then their triglyceride clearance at the adipose tissue is low. So these patients are having hypertriglyceridemia as well. I am just telling you something additional, but for the question, we have just asked how hypercholesteremia could occur in this patient. So other than this VLPL production, increase of VLDL production, which ultimately contribute to increase the blood cholesterol level. Also, other than that, there is some other explanation. What happens in diabetes? With the insulin deficiency, we know any body protein can get glycated due to chronic hyperglycemia. Due to insulin deficiency, patient can have chronic hyperglycemia. So when the patient is having chronic hyperglycemia, what can happen? Body proteins can get glycated irreversibly by an unenzymatic reaction. So same thing applies to here for lipoproteins as well. The lipoproteins which are in the blood can get exposed to this chronic hyperglycemia, and the LDL also can get exposed to that. So the proteins, apoproteins in lipoproteins, including LDL, can get glycated. So that changes its structure. So the binding capacity of LDL can get reduced to their receptors. So when the receptor binding of LDL is reduced, uptake of LDL by the liver and other peripheral tissues could be low. So that again can increase the blood level of LDL and also the total cholesterol level. Are you clear? Hello? Okay, now if we summarize, there are two main things that we discuss here. One thing is, three things. Because of insulin deficiency, there is mobilization of fat, and also there is increased lipogenesis, and then there is increased VLDL output from the liver, leading to increased LDL level in the blood, and also there is reduction in the uptake of LDL by the liver. So all will lead to increase blood cholesterol level in these patients. Right, that is that. So shall we do the next one? Can somebody read? There are additional things. I will discuss those after finishing. Can somebody discuss the next one? Vijay Cone. Vijay Cone, WMCM.
Yes, madam. Hemoglobin A1C is the gold standard to monitor the glycemic control in this patient with diabetic mellitus. Hyperglycemia increases non-enzymatic glycation of body proteins. Glycation of N-terminal of beta chain of hemoglobin A forms hemoglobin A1C irreversibly. The lifespan of red blood cell is 120 days. Therefore, plasma hemoglobin A1C level retain the glycemic control over the period of preceding 2 to 3 months. Hemoglobin A1C is less than 5.6 of total hemoglobin in a normal healthy adult. Hemoglobin 1AC level positively correlate with mean plasma glucose concentration. Therefore, as this patient have type 1 diabetic mellitus, which results hyperglycemia, his plasma hemoglobin A1C level is more than normal level.
Okay, good. Now I am basically giving you how we marked the paper last time, and you have to be little more into biochemistry as well. When you answer, okay, good. We will. Sorry. When you look at the report, as you can see, there is significant elevation of HbA1c in this patient. So, if I ask you this glycated hemoglobin, is it serum value or plasma value or blood value? What do you think? It is blood, because as all of you know, now if you just say fasting plasma glucose, that means you take the blood sample and you separate the plasma and get the assay done. But when it comes to glycated hemoglobin, this glycated hemoglobin is inside the red blood cells. So in this, when we do the test, we have to break the red blood cells and take the hemoglobin out, and that is how the technique is. So when we say it as blood glycated hemoglobin, blood. It's not plasma. Remember that it's not serum, because we are not separating serum or plasma when we do this analysis of HbA1c. Sometimes mistakenly you may say serum HbA1c, plasma HbA1c. No, not that. It's blood glycated hemoglobin. We measure the percentage of glycated hemoglobin from the total hemoglobin A1. Right? So, this patient is, first you interpret what you see. This patient is having glycated hemoglobin, higher value, and than the reference range, and it indicates that he is having poor glycemic control. And in patients with diabetes mellitus, you have to give this reference range when you write the answer. HbA1c, when it is equal or less than 7%, that shows relatively good glycemic control. What does that mean? good glycemic control. You have to tell this. That indicates low risk for microvascular complications and it predicts the prognosis. Say if it is less than 7%, that means patient is having a good glycemic control and is less likely to have microvascular complications and other related complications. That you have to tell. And that is the gold standard to monitor the glycemic control over a particular period of time. Say, if you just want to find out the glycemic level of the patient just at this moment, you may do random blood glucose level. But if you want to find out the glycemic control for a relatively longer period, maybe less than 3 months, the gold standard is to do the HbA1c percentage in blood. So what is the biochemical basis? As we know, when the patient is having absolute insulin deficiency or relative insulin deficiency with insulin resistance, whatever. Now, specifically addressing to this patient is having absolute insulin deficiency, having chronic hyperglycemia, can have non-enzymatic glycation of body proteins, that is non-enzymatic and irreversible. How that happens? Which part of the hemoglobin get affected? That also you have to tell. It's not okay. So in adults, major hemoglobin is adult hemoglobin A, and that is having 2 beta chains and 2 alpha chains. And this irreversible glycation, if it is irreversible, there should be a strong bond formation. So what is the bond form here? Covalent bonds. There is irreversible glycation of beta chains forming covalent bonds. This glycation happens at the N-terminal valley of beta chains of hemoglobin A. You have to remember that N-terminal valley of beta chains. That is bicovalent bonding, and that is an irreversible but non-enzymatic reaction. Once this glycation occurs, as we said, it's irreversible. It's therefore the lifespan of the red blood cell. Lifespan is about 120 days. So it remains in the blood for 120 days. So this percentage of glycated hemoglobin indicates the glycemic control over a period of 2 to 3 months or 6 weeks, 120 days, different ways they say. Right? Another important thing is this glycated hemoglobin percentage is positively correlated with the blood glucose level. What is that meant by? What does that mean? When the blood glucose level is increased, when it is rising, there is rise of HbA1c also. What is negatively correlated? When one parameter drops, other parameter also drops. Here, there is positive correlation between blood glucose concentration and the HbA1c. And HbA1c percentage is proportionate to the average blood glucose concentration over these 2 to 3 months. Right? And what else we can say? There are other advantages of this. There is no change of the HbA1c level with the diet, but if you take blood glucose levels, there could be changes if the patient is not well prepared. And no diurnal variation. Blood glucose level changes during the day. There are little changes. And it is not affected by acute metabolic stresses, unlike fasting blood glucose. blood glucose levels, of course, get fluctuated with the acute metabolic stresses where there is counter-regulatory mechanisms coming to play. But this HbA1c is not affected because it doesn't happen suddenly. And there is a drawback of this because this HbA1c percentage that does not show acute fluctuations, sudden acute fluctuations of glycemic control that could happen time to time, may not be showing. HbA1c shows the average glycemic control, not the acute fluctuation of blood glucose levels. And there is another disadvantage. What is that? See, if the lifespan of the red blood cell is reduced, say the patient is having hemolytic anemia, red blood cell lifespan is reduced. So that can reduce or change the HbA1c level. And say the patient has undergone blood transfusion, that again can change the level of HbA1c. And say the patient is having hemoglobinopathy or other hemolytic anemias like thalassemia, all will change the lifespan of the red blood cell. So that in those situations, this HbA1c may not be a useful marker. So that about HbA1c. The important thing here is, although we are relating this biochemical investigations to the patient, when you explain, you have to explain all this, the importance and what happens in diabetes. And there are marks sometimes allocated. If you say these values as well, what is more stringent control, what is less stringent control. This 7%, less than or equal 7% is the general value of HbA1c that you have to remember. That indicates good glycemic control if the HbA1c level equal or less than 7% in any person. But some individuals, a young patient with less complication, newly diagnosed patient, you want them to have a strict control, more stringent control. So in that case, we would like them to have a better control, having a lesser value of HbA1c. And they have little less risk of going into hypoglycemia. What is less stringent goal? Say there are older individuals having diabetes with all sorts of complications, and they had diabetes for a longer period. So they are very weak and friable, getting hypoglycemias time to time. And in that case, are we going to have a strict control on them? No. So we go for less stringent goals or less stringent control in these patients, having a lot of complications, having less life expectancy. So in that case, if we are okay, if the patient is having HbA1c level less than 8% as well, if possible, mention that as well. More stringent control is expected in these patients, and just if you can tell, that also be fine. But if you answer having these facts, that will be you will be scoring almost the full mark. Only 1 or 2 will be lost if you don't mention the less stringent and more stringent control. Okay. Shall we? There are some chats. One chat is there, one student. Shall we finish and we'll come back to this? Going into the next question. Can somebody... Okay. This is the next question. The following investigations are performed on a patient with acute viral hepatitis with jaundice. State the expected ranges and explain the biochemical basis in each of them. So, simply we have given you it as acute viral hepatitis. There is no case scenario given. It's straightforward. You can see the marks. You have to explain how serum total bilirubin get changed, what will happen to direct bilirubin, what will happen to serum alanine aminotransferase, and what is the result of Hayes test if you do that on this patient. Can somebody read the answer for the elevation of serum total bilirubin and direct bilirubin? Water. Can a boy read the answer? Any boy? Hello? Ruan Priya, are you there? Hello? Soisa. Soisa, can you read? Why?
Madam,
Yeah, can some boy read the answer? I don't know whether boys are there or not. Oh, like. Hello? Can somebody tell a name here? A boy. Okay, Soisa, can you read?
okay, madam. Acute viral hepatitis means infection and inflammation that occur due to certain viruses in the liver. Jaundice is a condition that skin and mucous membranes turn into yellow due to increment of bilirubin concentration in serum. Bilirubin is metabolized in liver. Therefore, if there is an infection or other something in liver, bilirubin metabolism will be impaired. Because of that, serum bilirubin concentration is elevated. Thus, jaundice occurs in acute viral hepatitis. In jaundice, serum bilirubin concentration is more than 2.5 milligrams per deciliter in serum. And due to viral infection in the liver, small hepatocytes are damaged. Therefore, the number of active hepatocytes are reduced. So bilirubin uptake by hepatocytes is reduced. Normally, conjugation of bilirubin is occurred in hepatocytes. In acute viral hepatitis, the above step of bilirubin metabolism is also impaired or reduced. Therefore, total serum bilirubin concentration is elevated while serum direct bilirubin levels are also increased. When acute viral hepatitis is more severe, the total bilirubin is elevated more than 30 milligrams per deciliter. Direct bilirubin concentration in serum is increased because there is also impairment in bilirubin circulation between liver and intestine. Therefore, direct bilirubin is entered into systemic circulation directly. Normally, conjugated bilirubin is excreted via intestine and kidneys. In this case, excretion via intestine is reduced. So, direct bilirubin concentration is serum is increased. Normal direct bilirubin concentration is in the serum is below than 0.3 milligrams per deciliter. But in this condition, it goes above the 1.2 milligrams per deciliter. That's it, madam.
Is that Indivari?
Yes, madam.
I couldn't recognize. So I just read the name. Okay. Now, uh, this is a case of acute viral hepatitis with jaundice. Now, we are very clear the patient is having acute hepatitis, inflammation of the liver tissue, and with that, what can happen? There could be cell damage. There is injury to the hepatocytes, and also there is inflammation in the hepatic tissue. There are two main things that we know. With that, what can happen? Uh, Basically, when there is inflammation and cellular injury, there is edema in the liver, and that can obstruct the intrahepatic biliary canaliculi. So that can reduce the excretion or release of this biliary content into the intestine. That is the main problem in acute viral hepatitis. And as all of you know, as there is hepatocellular injury, somebody might argue, okay, there could be a functional impairment, other functional impairment as well. But when it comes to bilirubin metabolism, as all of you know, the uptake and conjugation capacity of the liver is very high. Unless the liver is so damaged and the patient is so ill, conjugation and uptake of the bilirubin may not get affected. Right? Keeping that in mind, you should answer this question. Right. So elevation of total and direct bilirubin. There is, now we have given it as a broad thing in the question, serum total and direct bilirubin. Then you have to explain and tell what happens to these two parameters in patients with acute viral hepatitis. So the same thing can be given related to another scenario. Say what? Gallstone or carcinoma head of the pancreas. Different ways we can keep. So you have to first tell what is bilirubin. Bilirubin is produced from the breakdown of hemoglobin that happens in the reticuloendothelial system, and that is transported bound to albumin to the liver. And in the liver, these highlighted things should be there in the answer, right? And at the hepatocytes, these are conjugated to make water soluble by adding glucuronic acid, and that reaction is catalyzed by UDP glucuronide transferase enzyme. So this unconjugated bilirubin is made water soluble by making it conjugated bilirubin, or same thing is called as direct bilirubin. We know why we call it as direct bilirubin, because conjugated bilirubin directly reacts with the Vandenberg reagent. Then this conjugated bilirubin enters into the bile and into the intrahepatic biliary canaliculi, and then into the common bile duct, and then it is released into the duodenum for its functions. Right? And now we know for this answer, we don't have to tell what happens in the gut for bilirubin, because here the problem is basically the intrahepatic cholestasis. Right? And the question has been asked about the total bilirubin and the direct bilirubin, not about urobilinogen or anything, right? So after telling something in brief about what happens and how this bilirubin produced and conjugated, then straight away directly move to the this particular scenario. So then you come as in hepatitis, there is hepatocellular damage and inflammation. So with this inflammation, there is surrounding edema, and that edema causes blockage. There is compression on the small intrahepatic biliary canaliculi in the liver. So that leads to intrahepatic cholestasis. Then we have to tell about the normal bilirubin levels. Even in the very, if you don't remember these values, don't bother to remember the values. You have to have some idea, okay, what is more in blood, what is less in blood out of the conjugated and unconjugated bilirubin in normal individuals. So you say in normal individuals, serum unconjugated bilirubin level is more than conjugated bilirubin. It is the major component of bilirubin in blood. Total bilirubin, TB means total bilirubin. It's more than 95% of the total bilirubin. Conjugated bilirubin is very much less. So this patient having hepatitis and then intrahepatic cholestasis, what happens? There is stagnation of biliary content, bile inside the intrahepatic biliary canaliculi. That creates back pressure and reflux of bilirubin from the congested biliary canaliculi into blood. Here, when there is blood pressure and reflux, not only bilirubin, any other thing can go into blood. That includes what? Bile salts as well. Right? So, when this regurgitation occurs, there is entering of conjugated bilirubin into blood more than what is reflux in normal individuals. සාමාන්‍ය අයගෙත් ටිකක් යනවා. There is some reflux of conjugated bilirubin in normal individuals also. It is maybe less than 5%. But when there is biliary obstruction because of stagnation, back pressure and reflux, there is more conjugated bilirubin regurgitating into blood, increasing the blood levels of conjugated bilirubin. When it is more than 20% of the total, you say it has conjugated hyperbilirubinemia. So this patient, total bilirubin level is elevated because of the elevated conjugated bilirubin. Right? And there should be another statement you have to say to show that you know this. This patient is having because this patient is having hepatocellular injury. So you have to show that you know this other concept. Although there is hepatocellular injury, as the liver is having high capacity for uptake and conjugation for bilirubin, this unconjugated bilirubin level remains normal in the blood if the parenchymal damage is not very severe. ඒකේ පෙන්වන්න ඕනේ තමන් එක දන්නවයි කියලා. Basically, the problem here is intrahepatic cholestasis. At the end, you have to say, දැන් කෙනෙකුට ආගිව් කරන්න පුළුවන් නෑ මේ liver එක damage වෙන නිසා uptake එකත් අඩු වෙන්න ඕන, conjugation එකත් අඩු වෙන්න ඕන. Yes, possible. But that is very severe liver disease. Maybe a patient is in ICU, right? Very rare situation where this uptake and the conjugation gets so affected to have the unconjugated hyperbilirubinemia as well. But the predominant part is conjugated hyperbilirubinemia due to cholestasis, especially the intrahepatic cholestasis. Are you okay now? Okay. Next one. Can somebody read alanine aminotransferase? Samarasekara PK. Samarasekara PK. Can you read? I'm sorry, Sumanasekara. Hello? Sumanasekara, PK. Can you read the next part about Alanine aminotransferase. Okay. You see Vanigama JB. Hello? Can you can one of you read the answer?
And
Hello?
yes, madam.
Can you? What is your name, please?
Vanigama JB.
Okay, one.
Alanine aminotransferase is a cytosolic enzyme. It is predominantly present in hepatocytes. When there is hepatocellular damage, ALT level is released in large quantities. In viral hepatitis, there is also has acute hepatocellular damage. Therefore, ALT level is elevated largely.
Finished?
Yes, ma'am.
Okay, we will discuss. This alanine aminotransferase, you have to tell that where that is located, what is the role of it. It catalyzes transamination reactions in the liver, and it is a cytosolic enzyme. And it is predominantly present in the liver, mainly present in the liver. So then you have to tell, because of that, not only in the liver, but predominantly in the liver, because of that, it is more specific for liver disease. It is, then you have to give some examples for other tissues where you get ALT. There are some marks allocated for that also, 1 or 2 marks. Right? It is present in the kidney, heart, and skeletal muscles, but in small quantities. So, though having ALT elevated in diseases related to kidneys, heart, and skeletal muscles won't be very much specific. But if it is a liver disease, that is specific because it's more predominantly present in the liver. So, as it is a cytosolic enzyme present in predominant quantities, when there is hepatocellular injury, it is released into blood quickly in large quantities. These two terms are important. Large quantities, rapidly released into blood. That is why it becomes a good early marker. You have to write those, good early marker. And also, it is having, it is having short half-life. Why this short half-life is important? Say, if a marker is having a longer half-life, if it stays there for a longer period in the blood, you can't find out the changes in the course of the disease. Say, if it is an acute illness, for you to find out the changes in the situation of the disease, better to have a marker with shorter half-life. Right? So this ALT is having a 2 days half-life. So that is a good thing as an acute marker of acute hepatocellular injury. When you repeat the test in a few days' time, you can see what is happening to the patient, whether the hepatocellular injury is persisting, whether it's resolving. That idea you can get because it is having a short, relatively short half-life. So in hepatitis, what happens? So first you tell something very general about ALT and coming back into the specific scenario here. In this patient who is having hepatitis, what happens? There is increased membrane permeability. There is increased cell membrane permeability in this patient due to inflammation that increases leakage of ALT from the cells into blood. On top of that, this patient is having hepatocellular injury, depth of damage and depth of hepatocytes, releasing intercellular content into the outside. So this ALT is present in the cytoplasm, so it gets elevated in the blood quickly in large quantities. That elevation is earlier than the appearance of jaundice. Important, you have to tell, because for the elevation of serum bilirubin and to have the jaundice in the patient, you take little longer time than for the elevation of these liver enzymes. That is why even without jaundice, sometimes these serum markers get elevated. And also, it indicates the magnitude of damage. And due to very same reason, we can use this in the monitoring of the disease. When the magnitude of damage is high, it is very much high in the blood. If the damage is low, so the level of elevation is lower. And if it is, say, the patient is getting worse, the level of ALT is going up. And it is useful in monitoring the cause of the disease. These are all you have to write, right? Next one. Can somebody read the answer? Patyala. Patyala, can you please read?
His test is done to detect bile salts in urine. Normally, urine doesn't contain bile salts, but in here, his test can be positive. Bile salts are a component of bile which are synthesized from cholesterol in the liver. In acute hepatitis, due to destruction of intrahepatic biliary canaliculi, the accumulation of bile salts in the liver causes backward regurgitation into circulation. And since these bile salts are water soluble and they can excrete via urine, so the Hase test can be positive.
And we have to add certain things to that. There you have to little tell what you see in the Hase test as well. We'll see. So what is Hase test? First tell why we do Hase test for urine. That is to detect the presence of bile salts. Then you tell what is about the normal individuals. In normal individuals, bile salts are not present in urine, so Hase test is negative. Then you tell what are these bile salts, right? So bile salts are synthesized from the cholesterol in the hepatocytes as primary bile salts, cholic acids and chenodeoxycholic acid. Secondary bile salts are produced in the intestine. And these primary bile salts are present in the biliary secretions. And then they are secreted into the intestine. Their function is to emulsify the lipid in the diet and helpful in the digestion and absorption of fat and fat-soluble vitamins. These things, they are located with marks, right? And you just structure your answer when if this applies to any test. Say if it is Fuchs test, first tell what is Fuchs test. What about normal individuals? What does this Fuchs test detect? Right? That is how you should go, and then come back to the scenario or the patient. In this patient, what has happened? That is how, right? So in hepatobiliary disease, what happens? There could be intrahepatic or extrahepatic cholestasis that obstruct the biliary flow to the intestine, common biliary flow. Right? So, this patient, what is the problem? This patient is having acute hepatitis, having intrahepatic cholestasis mainly. And that causes, you don't have to sometimes explain in detail how this back pressure is created, edema, those things, because you have done that already in the first part of the question, right? So you can link to that as explained above. There is intrahepatic cholestasis and regurgitation of biliary content into blood, including bile salts. So the bile salts in blood is elevated, and that is water soluble. මේ චූටි චූටි උනාට ඒව ලියන්න වෙනවා. Right? Bile salts are water soluble and excreted in urine. Then what? Important things, right? Then you have to tell the quality of bile salts that we use for this test. Bile salts are antipathic, having hydrophobic and hydrophilic ends, and then it is having the emulsifying properties. Because of that, they can reduce the surface tension of liquids. So this bile salts reduce the surface tension of urine, and that causes what? When haze test is done, sulfur powder is sprinkled over the urine sample. So when the bile salts are present in the urine sample, what happens? Because of the reduced surface tension, there is sinking of the sulfur powder into the bottom of the tube. Hope you can remember the practical. We have done that. And in a normal urine sample, it floats. You can see here, in the normal sample, it is floating on the surface, but in the positive sample, you can see the sulfur powder is in the bottom of the tube. So that is what you have to explain. රූපෙන්ද නැති වුණාට කමක් නැහැ. Better for you to explain in the text properly. Right. Now, are there any questions? That finishes the proper tutorial. Right. Are there any questions in the chat box? I will just go through. There was a question. Is HbA1c used to diagnose diabetes? Heshan. Heshan innavada? Are you there? Heshan.
Yes, ma'am.
Yes. HbA1c can be used in the diagnosis of diabetes mellitus. Now I will stop. I think, where is that? Yes, that is there. Can you see this slide?
Yes. Yes, ma'am.
Criteria for the diagnosis of diabetes mellitus. You can see the ADA criteria 2013. There, HbA1c is there as a diagnosis criteria. When the HbA1c level is equal or more than 6.5%, that indicates the presence of diabetes mellitus. But you can see another thing there that should be done by a standard laboratory procedure. That is HPLC, high performance liquid chromatography technique should be applied when we do the HbA1c. But nowadays, most of the laboratories, they use the standard technique. Other thing is, most of the time we never go for HbA1c straight away because it's expensive. And we first do the fasting blood glucose level. So at the exam, never tell that you are doing HbA1c. at first instance. You start with, you can see, start with fasting plasma glucose, right? That is why I have made this as first. Generally, in local setting, we do fasting plasma glucose in the patient, and right, and then you can do the HbA1c as well. But if it is in a question asked as HbA1c is used in the diagnosis, that is true, right? So there was another question I got earlier from WhatsApp. Somebody asked me, I can't remember who was that, was asking whether that they can use random blood glucose for the diagnosis of diabetes mellitus. That is also here. That is again here. You can see random plasma glucose can also be used in the diagnosis of diabetes mellitus. But there is a criteria here. What is the criteria? Patient with classic symptoms of hyperglycemia or hyperglycemic crisis. What does that mean? Say, now I think I am having diabetes. If I just go and do random blood plasma glucose, can you use that as a diagnosis? Can you use in the diagnosis? No, you can't, because I don't have classical symptoms of hyperglycemia or hyperglycemic crisis. Say I am admitted to a ward with DKA or non-ketotic hypersmolar coma. Of course, when you do the random plasma glucose, if it is high, that is diagnostic, because you have all sorts of that you are in hyperglycemic crisis. And also say if I am having so much polyuria, polydipsia, I am wasting my weight, I am wasted, recent weight loss is noted. So in that case, when I go and do random plasma glucose with all classical symptoms of hyperglycemia, if it is well above this 200, that is diagnostic. Understood? Understood. I don't know who asked that question. That was in my WhatsApp. Hope that the person who asked the question is there. Some names I could remember. What else in the chat? And Kirti, hello.
Yes, madam.
There were some questions you sent to me.
Yes,
shall I give the answers now?
yeah, okay, madam.
Okay. Can you remember those questions?
Yes, madam. It was regarding hyperammonia.
No, I can remember what you asked. One thing is, in hyperammonemia,
Yes, madam.
will there be a change in blood-brain barrier permeability? That
Madam,
neither. That is,
I thought yes, because since the astrocytes are getting affected,
sorry.
Madam, I thought the permeability there is a change because the astrocytes are being affected.
Kirti, I can't hear you.
Madam, I thought there is a change in permeability because the astrocytes are getting affected there in hyperammonia.
Oh, astrocytes are there also in the blood-brain barrier. Now, basically, what happens in this hyperammonemia, hope others will also find useful. What are the conditions where you get hyperammonemia mainly? In liver failure and also in urea cycle disorders. In hyperammonemia, there is change in the permeability of blood-brain barrier. Right? There is change in permeability of the blood-brain barrier that is said to be due to hyperammonemia itself, or also this hypoammonemia triggers cytokine-mediated inflammation. As all of you know, when there is inflammation, there is changing in the permeability. So, in hyperammonemia, there is change in permeability of the blood-brain barrier, And also there is increased transcellular passage of molecules. අතරෙත් transcellular passage එකක් වෙනවා. Right? And there was another question. What were your other questions? That you have asked about inborn errors and carbohydrate metabolism. What are the areas that could be questioned? The areas that I taught in inborn errors of metabolism under carbohydrate metabolism are not going to be basically questions separately, but if you can remember the management methods of inborn errors, there are under certain management options, there are certain things that we have to include as examples. For that, you had to include some of the examples that we discuss in inborn errors of metabolism under carbohydrate metabolism. Not specifically I am going to ask on McArdle's disease, on just not, right? But if you remember, galactosemia will be asked, right? Galactosemia, which I think Kamani madam taught, that part is going to be question. And there was another question sent to me, I think a boy. Any other questions you want to ask from me? I am answering this, giving the Saumya. Saumya, are you there? Saumya Seniviratna. Hello? She's not there. She also asked me questions. See whether she's there. Saumya, I don't. Seneviratna, no, I think no. Anyway, sorry. I will discuss things that I have prepared that otherwise aparade. Now, some student, a boy, I can't remember the name, he has asked me through the WhatsApp where mainly this iron absorption occurs. What is the intestinal site? That is actually the iron absorption primarily occurs in the duodenum and the upper jejunum. Mainly it occurs in the duodenum. And there was another question posed to me via WhatsApp. That was whether babies with galactosemia, they have jaundice or not. Yes, they can present with jaundice. They generally have unconjugated, they have unconjugated hyperbilirubinemia, right? And some they have asked the Karawat other whether they can use AST as a current biomarker in the diagnosis of myocardial infarction. I think you all know you can't use AST, aspartate transaminase, as a current biomarker of myocardial infarction. What are the current biomarkers of myocardial infarction? Those are creatine kinase, total and creatine kinase MB, and cardiac troponin and myoglobin. What are the given up or out of dated ones? What are the out of dated ones? Lactate dehydrogenase and aspartate transaminase. Those are not used currently. And one boy, I think, he has asked me whether captonuria gives positive test for Benedict test, positive results for Benedict test. So what are the conditions or situations where you get positive results of Benedict test? If the urine is having what? Urate, reducing sugars, vitamin C, thymol, formaldehyde, dextrine, lactic acid, gluconate, and also alkaptons. But remember, in alkaptonuria, the color that you get is black colored ring. In Benedict, that is said as Benedict test is positive in alkaptonuria, but the color that you get is black. And there was another question, I don't know from whom, that the student had asked why this unconjugated bilirubin present in normal individuals, which is less than 5%, sorry, which is about 95%, is not excreted in urine. That is obvious. And if you carefully go on through the lecture handout and the PowerPoint, you can understand why unconjugated bilirubin is not present in urine. Because unconjugated bilirubin is not water soluble. Though it's present in the blood in large quantities, that is not excreted because it's not water soluble, and it is bound to albumin, and it's present in a relatively large molecule which cannot get excreted, right? And then the other one they have asked is, what are the enzyme markers of hepatobiliary obstruction? What are the two main enzyme markers of hepatobiliary obstruction? Alkaline phosphatase and gamma glutamine transferase. Those are the enzymes that get elevated when there is hepatobiliary obstruction. Any other thing? Any questions you have? And Kirti, hello.
Yes, madam.
You asked me another question, no? About protein and hyperammonemia. What does that?
Madam, that's about like madam, in case of hepatic
Yes.
encephalopathy, like for the
I can't hear you
we will limit
properly.
the protein.
Yes,
Madam, now?
possible.
Madam, in case of hepatic encephalopathy, as a treatment, we will limit the protein intake, no, madam.
Yes.
Like, we don't give low levels of protein for the person according to his requirement. We will limit the protein intake. We don't restrict or give low levels. Is that so, madam?
Now, it depends on how severe the hyperammonemia is. Say if the patient is having very severe hyperammonemia and patient is in coma or stupor, you stop all external sources of protein for about 20, at least 48 hours. It depends the severity of hyperammonemia. Otherwise, if the patient is well and okay, even the patient is having hepatic not encephalopathy, even the patient is on liver failure regime, you have to give some protein, which are very high quality protein, producing less amount of waste. Say, patient is having liver failure, but he is relatively okay on the liver failure regime. We are giving good quality protein, limited amounts to meet the requirement. But say if the patient is having severe hyperammonemia, then you restrict. Then you sometimes stop all proteins for 48 hours or a little longer, depending on the patient's situation. It depends, right?
Okay, madam.
Otherwise, if you stop protein in a liver failure patient for so long, that they can end up with malnutrition. Depends on how severe the hyperammonemia is. Whether you are going for a total restriction of protein or no, it depends. Any other questions? Anybody? Any other question? No questions.
Excuse me, madam.
What? Can you?
Madam, when we are studying about the heme synthesis pathway, should we remember all the steps in that pathway?
Heme synthesis here, who did, Erickson did that, ne? You have to remember that, at least you have to remember regulatory pathways, neither. ALA synthase, that thing. I better to ask from Erickson because he is the one making questions. At least now, when you take any pathway exam, generally, any pathway, if you can't remember all the steps, what are the steps you should remember? Where there is a regulatory enzyme involved, where there is, say, regulatory in the sense what? There are a lot of positive feedbacks, negative feedbacks, drug involvement, all comes into one step. So that step you have to specifically remember. Say there is a irreversible step. There is a step where insulin, that is insulin dependent. That is the main rate limiting step. So those steps you have to remember, dear, because many questions will be placed in such areas. Not that all the steps for any metabolic pathway.
Okay, madam. Thank you.
Okay. Anything else?
Hello, madam.
Yes.
Madam, in a type 2 diabetes mellitus patient, and that person is not in treatment also, and that person has become confused, and her urine level is of course positive for glucose, then is the probable diagnosis hyperglycemic hyperosmolar coma,
Yes.
or else cerebrovascular accident, madam?
No. That is, we are doing biochemistry. So, type 2 patient, old patient, having positive urine, positive for glucose or whatever, positive Benedict test, in coma, not on treatment, all that indicates hyperosmolar, hyperglycemic, hyposmolar, non-ketotic coma. Maybe the patient is having cerebrovascular accident as well, but the answer is that hypersmolar, hyperglycemic, non-ketotic coma.
Okay, madam. Thank you, madam.
Okay. I just want to, I don't know, Saumya is not there. I just made this because of her. Anybody can learn. I will just share this with you. Right. Can you see this slide?
Yes, madam.
Okay. Now, just for you to understand what happens, like two differences. She was sending me many questions, right? But she's not there in the tutorial, right? Type 1 diabetes. What is the problem in type 1 diabetes? Absolute insulin deficiency is there. Type 2, insulin resistance plus or minus relative insulin deficiency. In the initial phase of type 2, you may not have sometimes relative insulin deficiency. Right? So what abnormalities can this type 1 patient they can have? Related to lipid metabolism. As we discussed today, they can have hypertriglyceridemia. And also, we didn't explain, they have reduced HDL. They have reduced activity of LDL receptors. So these patients, type 1, they can have hypertriglyceridemia, hypercholesteremia, elevated total cholesterol, elevated LDL, all that, reduced HDL. And other than that, these patients, we know that they can go into ketoacidosis, right? But type 2 patients, they can have all the lipid abnormalities that type 1 patient is having, but not ketoacidosis. Right? Because type 2 patients, they are having spared some insulin to prevent the ketogenesis. Understood? So these type 1 and type 2 patients who are having poorly controlled diabetes can have dyslipidemia, which constitute hypertriglyceridemia, reduce HDL, and increase cholesterol. So, if I ask you, there is in these patients, there is increased triglyceride synthesis, true or false? That is true. As we discussed, there is lipogenesis, increased fatty acid beta oxidation, yes. Increase fatty acid mobilization from the adipose tissues. Yes, we discussed that. Because of reduced insulin to glucagon ratio, there is activation of hormone-sensitive lipase at the adipose tissue, leading to triacylglycerol breakdown and mobilization of that. And that is taken up into the liver, fatty acids, and subjected to beta oxidation, and these are the producing acetyl-CoA, ultimately producing cholesterol, glycerol, and also fatty acids, leading to increased lipogenesis. I can't remember the other one. That is what, right? So can't. Any other question? And these patients, basically, they can have increased levels of free fatty acids in the blood if they are not properly controlled. Right. What else? Any questions? I think I answered most of the questions that were posted in the WhatsApp as well. If you have any questions, we can answer. If not, we can stop. Shall we then stop? We'll see the chat and then stop. Any. What happens to the endogenous cholesterol synthesis is increased. That is what we discussed. Because the precursor for the cholesterol synthesis is, if I show you another slide, just give me. What is the precursor for the synthesis of cholesterol? What is the precursor for endogenous synthesis of cholesterol? Anybody?
Acetyl-CoA, madam?
Yes, acetyl-CoA. When the acetyl-CoA is produced in excess, there is increased production of cholesterol. I will share that again. There was a slide to show that. I think you could remember the now can you see a slide at the moment? Can you see the slide? See a slide?
Yes, ma'am.
Okay. Now, if you just refresh your memory, fatty acid synthesis, acetyl-CoA is the precursor. That was why I was telling when there is increased acetyl-CoA production, there is increased production of fatty acids. And using those fatty acids, triglycerides are produced in the liver. Right? In the same way, if you can remember, acetyl-CoA is the precursor for the synthesis of cholesterol, right? So when the precursor is high, there is mobilization of stored fat in the adipose tissue. Because of insulin deficiency and resistance, there is lot of fatty acid coming into the liver due to lipolysis there in the adipose tissue. That provides the acetyl-CoA, the precursor for the synthesis of cholesterol and for the synthesis of fatty acids endogenously. So that increases triglyceride production as well as cholesterol production. But somebody might argue, what is the argument? Can somebody think of something? Somebody might argue, okay, how can that happen? This patient is having insulin deficiency or insulin resistant, because insulin is an anabolic hormone. You need insulin for these synthesis processes. But on top of that, even there is insulin deficiency or even there is insulin resistance, there is lot of flux, there is lot of substrate for the patient to produce fatty acids and cholesterol. So in these patients who are not under control, they produce triglyceride and the fatty acids and cholesterol, and then from fatty acids and glycerol producing the triglyceride, and more VLDL is produced and sent outside from the liver. And also there are some other adjustments, as we said, due to low insulin and insulin deficiency, lipoprotein lipase activity is low in these patients, so triglyceride clearance is low. That is why patients are getting hypertriglyceridemia. There is increased VLDL production, which is having triglyceride, but the triglyceride clearance is low in the peripheral tissues. So the patient is having hypertriglyceridemia. When VLDL is produced more LDL is also produced from that VLDL. But as we said, this LDL can get glycated. When those are get glycated, the receptors can't bind to them. So more LDL will be produced and remain in the blood with the inability to take up into the peripheral tissues and to the liver. So that elevates the LDL and the total cholesterol level in these patients. Right? Understood? Okay, shall we stop there? So we'll stop now. If you have any questions, even you can ask me later. Okay then? Okay.
Okay, madam. Thank you.
Thank you, madam.
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 Okay.
Thank you, madam.
Recording stop.